So I'll move ahead. So before moving to the class of anticoagulant drugs, I will brief upon the coagulation pathway. So this is very important because I'll tell you there are three pathways and the different factors which are involved. The drugs acts on those particular factors. So it is, we'll just take a short glimpse of 2 minutes of what is the coagulation pathway. So if you see, there are three pathways. One is a common pathway, one is an intrinsic pathway, and one is an extrinsic pathway. So these are three pathways by which the coagulation occurs in the body. So how these different clotting factors talk to each other, how do they get activated, we'll cover all of these. So the first is the common pathway. So we know that in any type of sport, like the best player of that sport, be it cricket, hockey, football. So the best player of that sport has a jersey number 10. So again, that jersey number 10 player remains in the center of the field. Similarly, the factor 10, which is the most important factor in this entire coagulation pathway, this remains in the center of the entire pathway. So this is in the common pathway. So this factor 10, the coagulation starts when this factor 10 gets activated to factor 10A. Now, how does this happen? How does factor 10 get activated to factor 10A? We'll move first to the intrinsic pathway. Now, intrinsic pathway occurs when there is a break in the blood vessel and the endothelium, which is the inner layer, slightly breaks and the blood, circulating blood, comes in contact with the collagen. So this is called intrinsic because the blood vessel is not entirely broken, only the inner lining of the blood vessel is broken and collagen is exposed to the circulating blood factors. So it remains intrinsic. The blood, if the blood vessel is entirely broken and the outside tissue is exposed, it becomes an extrinsic pathway. So as soon as a contact with collagen occurs, blood vessel is not entirely broken, only the contact with endothelium occurs with the circulating clotting factors. What happens? The factor 12, 1 to 12 gets activated to factor 12A. This factor 12A activates factor 11 to factor 11A. This factor 11A activates factor 9 to factor 9A. So if you can see a sequence, there is factor 12, 11, 9. The factor 10 is missing because 10 has already moved to the center of the field, which is common pathway. So it will run from the remaining will come on the left, 12, 11, 9. And this factor 9 will then activate factor 10 into factor 10A. This is the intrinsic pathway on the left. Now we move to the right on the extrinsic pathway. This becomes activated once there is tissue damage. So the blood vessel is entirely broken and the blood vessels, the circulating clotting factors are now in contact with the external tissue factors. So that's why it is called extrinsic, outside. So the blood vessel, the blood clotting factors gets exposed to the outside tissue. So once this happens, the factor 7 gets activated to factor 7A, and this 7A activates 10 to 10A. So on the left side there is 12, 11, 9. On the right side it is 7, and in the center it is 10. So now the factor 10A activates prothrombin, which is factor 2 into factor 2A. Okay, and this factor 2A changes fibrinogen to insoluble fibrin. So insoluble fibrin is actually the clot. So this is the clot. Fibrinogen changes to insoluble fibrin, and the clot forms. So in entire field, if any drug blocks 12, 11, 9, factor 7 is still functioning. If any other drug blocks 7, 12, 11, 9 is functioning, so clotting will keep on continuing. So what the best approach is to either block factor 10 or factor 2. So all the drugs which we will be subsequently discussing, they will either block factor 10 or they will block factor 2. Okay. So all the drugs will be blocking 10 or 2 because common pathway has to be blocked for clotting to be entirely blocked. Now we move ahead. So this is the clotting factor. I just wanted to bring it up to just highlight that all the drugs are acting on either factor 10 or factor 2 or both, because that is a center and the common pathway. Now we move ahead and we will now see there are two groups of anticoagulant drugs. How do they act? So they act, one, by inhibiting the synthesis of vitamin K dependent clotting factors. So clotting factors are not formed. they block the formation of clotting factors in the liver. So clotting factor synthesis is blocked. So what are those clotting factors which are synthesized in liver and which is blocked by this class of drugs? It is 2, 7, 9 and 10. So this is a common question which is asked. Which are the vitamin K dependent clotting factors? And this synthesis occurs in the liver. So this group of drug on the left blocks synthesis of 2, 7, 9, 10. On the other hand, on the right side, there is another group of drugs which do not block the synthesis of vitamin K dependent clotting factors, but they block already formed clotting factors. So they are already circulating in the blood. So they attack those factors and kill them. So which are the two factors we talked about in the previous slide? It was number 10 and number 2 in the common pathway. So all the drugs acting on the preformed, पहले से बने हुए, all the preformed clotting factors will be working on either 10 or 2 or both. And the other group will not, which are not acting on the preformed factor, they will block the synthesis of factors in the liver. Now, which are those drugs? We can move to the left side. The drugs which block the synthesis of vitamin D dependent clotting factors in the liver are warfarin, and the drugs which act and kill the circulating clotting factors 10 and 2 are all the other drugs, heparin group and all the other drugs. We will come to all the other drugs. So is it clear till now that there are clotting cascade has 3 pathways, common in the center, intrinsic on the left, extrinsic on the right, common there are factor 10 and factor 2. So we'll have to kill factor 10 and factor 2. And then there are 2 classes of drug. One inhibits the synthesis of vitamin K dependent factors, which is 2, 7, 9, 10, and one which kills already preformed, which are circulating clotting factors. So they are 2 and 10. Now we move ahead to the classification of drugs, which is the most important, and this is the most difficult because I used to struggle in my days. So I wanted everyone to have a quick look at this. So in this, you see there are 2 groups, basically the oral group and the parenteral group. Simple, 2 groups hai. To remember the classification, I'll make it very simple. One is oral, orally lete hain. The other one is parenteral, given by injection. Okay? In oral group, there are 3 subcategories: vitamin K inhibitors, factor 10A inhibitors, and direct thrombin inhibitor or factor 2A inhibitors. I'll tell you that factor 2 is also called thrombin. So wherever we will talk about thrombin, we will be referring to factor 2A inhibitors. So there are 3 groups in oral. One is vitamin K inhibitors, one is factor 10A inhibitors, and the third one is factor 2A inhibitors. Now we come to parenteral. Here we have another 2 groups: indirect thrombin inhibitors, which is indirect factor 2 inhibitors, and direct factor 2 inhibitors, direct thrombin inhibitors. So now it is easy. In oral, we have 3 groups: vitamin K inhibitors, factor 10A, factor 2A inhibitors, 10A and 2A separately. In parenteral, they are all 2A, but there is indirect thrombin and direct thrombin. Thrombin is factor 2. Just remember, thrombin is factor 2. Now we will look at drugs in each category. Vitamin K inhibitors, I already told you in the previous slide that there is warfarin is the drug which blocks the synthesis of vitamin K dependent clotting factors in the blood. So warfarin and coumarin group of drugs. So warfarin belongs to a group of drugs called coumarins. So warfarin, dicoumarol, acinocoumarin, and there is another group of drugs called phenandione. So there are 4 drugs: coumarin group, which consists of warfarin, dicoumarol, acinocoumarin, and phenandione. Simple, they are vitamin K inhibitors. All the other drugs are either 10A or 2A inhibitors. Okay. So now in the previous slide we looked at that drugs inhibiting factor 10A and 2A are all other drugs. Only vitamin K inhibitors are warfarin group. All others are acting on either 10A or 2A. So moving on to 10A, we have 2 drugs, rivaroxaban and apixaban. Now you can just see in factor 10A, it is written on highlighted in yellow. 10 is written in Roman numeral as X. So factor 10A, XA, and rivaroxaban and apixaban also has XA. So if you find XA in the name of the drug, they are automatically factor 10A oral inhibitors. Rivaroxaban ko we can also remember that O. O stands for oral, 10A stands for XA is 10A, and BAN is ban or antagonist. So if you in an MCQ or in any question you find there is XA in the name of drugs, they are factor 10A inhibitors. Now moving to direct thrombin inhibitors, oral class. So we have two drugs again, important two drugs, dabigatran and zymalagatran. So now you will observe in the further groups that wherever you get TR in the name of the drugs, TR, these are thrombin. So thrombin also has TR. So if you get TR, they are thrombin inhibitors automatically. If you have XA, they are factor 10A. If they have TR, they become thrombin or factor 2A inhibitors. So dabigatran, zymalagatran, TR stands for thrombin, AN stands for antagonist or inhibitor. Clear till now? Vitamin K inhibitor, oral mein we are working on oral. Oral mein there are three groups: vitamin K inhibitors, warfarin group, dicumarol, factor 10A, factor 2A. 10A is very easy: XA, rivaroxaban, apixaban. Direct thrombin oral, TRAN, thrombin inhibitors. 3R stands for thrombin. Now we move to parenteral inhibitors. So parenteral mein we have indirect and direct. In indirect, they are called indirect because they do not directly inhibit, but they act indirectly by activating first antithrombin 3, and this antithrombin 3 then kills thrombin. So there is a mediator in between, antithrombin 3. So it is working indirectly, not directly inhibiting thrombin, but acting by activating antithrombin 3, and then antithrombin 3 goes and kills factor 2. So in this class, there are three indirect thrombin inhibitors. There are three classes: unfractionated heparin, low molecular weight heparins, and other heparins. So they are all heparins. Okay. So in unfractionated heparin, let us first look at the drugs. We have traditional heparin. In low molecular weight heparins, we have enoxaparin and dalteparin. And in other heparins, we have fondaparinux and idraparinux. So you observe some trend. It is very interesting. So just have a look. Whenever you get a PARIN, parin in the name of the drugs, I have highlighted in red: heparin, enoxaparin, fondaparin, nux, parin. They are all heparins. No confusion. If you have PARIN, they automatically become heparins. Okay, and heparins are obviously they are not given orally. They are parenteral drugs and they are indirect thrombin inhibitors. Now move to the last group, which is parenteral direct thrombin inhibitors. We have hydrodin, pevaluridin, lepirudin, and argatroban. So you have rudin and TR. So just observe here. So if you get TR or rudin in the names, TR or rudin in the name of the drug, they are automatically direct thrombin inhibitors. TR stands for thrombin and AN is antagonist. So TR aega, if TR is there, automatically put it as thrombin inhibitors. If you have TRAN consecutively, AN after TR, it becomes oral. If there is TR but AN is not after that, or you have rudin, they become parenteral. So this is a very easy classification. I think you will be able to remember. Now you will be able to solve all questions. If you have parent, they are all heparins and indirect inhibitors. If you have rudin or TR, they are thrombin inhibitors. If they have XA, they are factor 10A oral inhibitors. Now we will move forward again. Okay. So now observe. This is the same chart, but I have presented it a little differently. Now what happens? We have talked about that all the drugs apart from the first class, which is vitamin K inhibitors, because they are blocking the synthesis in the first place. Now let us forget that. All the remaining drugs are either acting on factor 10A or acting on factor 2A or acting on both. They are inhibiting both or are inhibiting either one of them. So we have just talked about factor 10A, which is rivaroxaban, apixaban. We know the first arrow going down, it inhibits factor 10A. Now come on the right side, direct thrombin inhibitors. We already know they are factor 2A inhibitors. Coming to the heparin, heparin is slightly different. So the traditional unfractionated heparin, it inhibits both factor 10A and 2A. So heparin inhibits both. That's why it is called PAIR, pair. But this is only applicable for traditional heparin. It blocks both. But the other two groups, which is low molecular weight heparin and other heparins, which are enoxaparin and fondaparinux, they inhibit only factor 10A. So this is important. Factor 10A, rivaroxaban, apixaban. If you have TR, they are all factor 2A. Heparin, traditional heparin, inhibits both 10A and 2A, and low molecular weight and other heparins, they inhibit only factor 10A. Okay. Now, in a summary, this is a summary of whatever we have discussed in the classification and the tricks. So what happens is, we know there are synthesis inhibitors. In synthesis inhibitors, what we have? The coumarin groups, the warfarin groups, the phenedione. They do not inhibit any clotting factor, but they inhibit the synthesis of clotting factors in the liver. So they are inhibiting synthesis, but whatever is circulating in the blood, they are not touching them. They are only inhibiting it, the new formation in the liver. This is one group. Now factor 10A inhibitors. Which are those drugs? So this is another catch. So any drug with letter X is factor X, 10A. Okay, you just check. Rivaroxaban, apixaban, I told you. In the heparin group, the other group, low molecular weight and the other heparins had enoxaparin, fondaparinux, and idraparinux. So all these drugs have letter X. So if you get letter X, it is automatically factor 10A inhibitors. If you get letter XA together, like in the first two instances, rivaroxaban, apixaban, if you get this, they are oral uh, inhibitors. So by a thumb rule, if you get letter X, they are all factor 10 inhibitors. There is one exception, that there is some low molecular weight heparins such as dalteparin and tinzaparin, which do not have letter X, but they are also factor 10 inhibitors. But on a uh, by and large, this rule holds true. So in any other MCQ exam, if you get this, X is 10. Okay. Then we'll move to factor 2A inhibitors. Okay. In factor 2A inhibitors, all drugs with the letter TR. Factor 2 is thrombin, we know. So thrombin has TR. So any letter with letter TR or rodin, they are all factor 2 inhibitors. Dabigatran TR, simelagatran TR, argatroban TR, or rodin. So this is pretty simple, I think. You can remember this. Now I move to the last drug, which is inhibiting both factor 10A and 2A, and this is only one group, which is the traditional unfractionated heparin. This is inhibiting both factor 10A and 2A. By this, you can remember the classification, and easy for you to decode which drug is which drug is acting where. Now with this, I'll move to some pharmacology section. So quickly, I'll check with important features of heparin. So in heparin, I will move to the first point, which is the presence. So I'm talking first about heparin, then I'll talk about warfarin group. So heparin are indirect thrombin inhibitors. They do not directly inhibit thrombin factor 2, but they do so by activating antithrombin 3. So heparin is the strongest organic acid in the body. It is present in mast cells, and in the mast cells, it is present mostly in lungs, liver, and intestinal mucosa. So LLI is the code. So if somebody asks you where is it located, mostly, but it is mostly located in the mast cells of lungs, liver, and intestinal mucosa. Routes of administration: heparin is not given orally. It has a strong electronegative charge on its molecule. So because of the electronegative charge, it will not be absorbed orally. So it will never be given orally. It is given only by parenteral route, and in parenteral route, it is given subcutaneously or intravenously. Never given IM, because there is a high chance of hematoma formation. So intramuscular route is avoided, not to be given. It is only given by subcutaneous or intravenous route. Third, the onset of action. So heparin acts immediately. If you give IV, it will act within minutes. If you give subcutaneously, it will act within 1 to 2 hours. Action is immediate because it inhibits the already available clotting factors in the blood. So clotting factors are circulating, it kills them, and the action is immediate. Warfarin, it is the other way around. Mode of action, I already talked about. It activates antithrombin 3, which then activates clotting factor 2A, or in heparin, in the case of heparin, it blocks and both clotting factor 10A and 2A. Okay. Now I move ahead. So side effects. So any anti-clotting drug, if you get across, the only and the major side effect remains is bleeding. So there is a chance of bleeding if there is a slight overdose. So this is the most important side effect. But in heparin, there is another important side effect which comes by the name of thrombocytopenia, which is decreased platelet count. So bleeding is the most common side effect of overdose. Once internal bleeding starts, hematuria, which is your blood appearing in the urine, is the first sign of bleeding. Bleeding is treated with fresh frozen plasma because it provides new factor 2 and factor 10. But the specific antidote is protamine sulfate. And in heparin-induced thrombocytopenia, this is a rare case, but it is a very important case. In case it occurs, it is very serious. So this is heparin-induced thrombocytopenia, as the name suggests. There is decrease in the counts of the platelets below 1 lakh. It occurs, it is an autoimmune condition, so it occurs due to antibodies against heparin and platelet complex. It occurs 5 to 10 days after starting heparin, and it may result in paradoxical thrombosis. So we have you are giving heparin to treat thrombosis, but in this condition there is paradoxical thrombosis, so thrombosis can occur. The treatment for this is to immediately stop heparin, start IV thrombin inhibitors. So heparin is not to be given, stop. Even low molecular weight heparins also are not to be given. The treatment is thrombin inhibitors, which is argatroban or lepiridine, and that too the IV drugs, IV thrombin inhibitors. Moving ahead, then we have low molecular weight heparins. So low molecular weight heparins is developed from heparin to improve some features which disadvantages that the heparin had. So to improve them, low molecular weight heparins were developed, and these are the drugs which selectively inhibits factor 10A. We talked about that heparin is inhibiting both factor 10A and 2A, but low molecular weight heparins and other heparins. Low molecular weight heparins are enoxaparin, dalteparin, tinzaparin, and the other heparins are selective inhibitors of factor 10A. They don't touch 2A that much. The other advantages are of low molecular weight heparin over unfractionated heparin becomes that low molecular weight heparin has a better subcutaneous bioavailability, 70 to 90%, as compared to unfractionated heparin. So if you inject a drug subcutaneously, the amount which is available for action is the bioavailable drug. So in unfractionated heparin, it is 20 to 30%, and in low molecular weight heparin, the bioavailability of subcutaneous route improves to 70 to 90%. Okay, the other advantage is that there is more predictable response, less variability. So suddenly the level goes up, the chances of bleeding increases. That doesn't happen that much in low molecular weight heparin because it is a more predictable response and there are lesser chances of bleeding. Third, it has a longer and more consistent half-life. So better availability, more predictable response, longer and more consistent half-life. Less chances of heparin-induced thrombocytopenia. So this is a very serious condition. If it occurs in only less than 1% of people who are getting heparin. But if it occurs, it is very serious. So this is the chances of low heparin-induced thrombocytopenia is lesser with low molecular weight heparins. Lab monitoring by APTT measurement is not required in LMWH. So once you give heparin, to monitor if it is not like the anticoagulant action is not occurring to a higher extent and there is no chance of bleeding, you have to continuously monitor it by taking blood samples and checking for APTT levels. So with LMWH, the lab monitoring is not required. So this is another big advantage of this. And in most instances, LMWH are now being preferred over unfractionated heparin as a means of anticoagulation. In most instances, there are some in which heparin is preferred, but in most instances, this LMWH are preferred. So these were the advantages of low molecular weight heparin. So I'll stop heparin because it is too much of a data. Now I'll touch upon warfarin. So in warfarin, how does it act? So I have already talked about that warfarin acts by inhibiting the synthesis of vitamin K dependent clotting factors in the liver, such as, remember these, they are always asked 2, 7, 9, and 10. So they do not touch the already circulating clotting factors in the blood, but they inhibit the synthesis of new factors. Okay, and routes. So heparin we talked about. Heparin is parenteral. Warfarin is given only orally because it has a very good oral bioavailability. So this is given orally. It is 99% plasma protein bound. Okay. Then comes the onset of action. With heparin, we had immediate action. As soon as you give heparin, within 15 minutes of the IV dose, it starts acting. But here the onset of action is delayed. It is but obvious because it will take time to block the synthesis of new clotting factors. The clotting factors which are already in circulation, they'll keep on acting for 3 to 5 days till they have their life. So by the time they fizzle out, they die down their own life, and by the time the new ones are blocked, it takes 3 to 5 days. Hence the onset of action is delayed. For heparin, it is immediate. Side effects. So again, if for anticoagulant drugs, if any question comes, just remember an overdose of anticoagulant drug, bleeding is the most common side effect. It can occur. For warfarin, there are two other important side effects apart from bleeding. This is skin necrosis. So there is a purple toe syndrome, skin necrosis, alopecia, and diarrhea. These are important. You should always remember warfarin skin necrosis is a very, very important condition. and then we can have alopecia and diarrhea. If the bleeding occurs with warfarin, what will you do? Stop warfarin and give fresh blood transfusion and fresh frozen plasma. So bleeding will only occur when the circulating factors have died down and the synthesis has stopped to that extent that there is so much, the level of clotting factors decreases by a huge margin and there is increased chance of bleeding. So stop warfarin, give, but the new clotting factors which will be now be developed after stopping warfarin, it will take time. So in the meantime, give fresh blood transfusion and fresh frozen plasma so that the person can have immediate clotting factors for replenishment. Then vitamin K1 is the specific antidote. So this is common, like uh, warfarin was inhibiting vitamin K, and so if you give vitamin K, it becomes an antidote. But it takes 6 to 24 hours for new clotting factors to be synthesized. So these are important points about warfarin. And the last and the most important point, warfarin is absolutely contraindicated in pregnancy. It has never to be given. In pregnancy, if anti-clotting drug is required, it is always and always heparin. Okay. So because warfarin can cause fetal warfarin syndrome, so when the baby is born, there can be hypoplasia of the nose, eye socket, hand bones, and there is growth retardation and other multiple CNS defects. So which is known as fetal warfarin syndrome. This is a condition. So not warfarin not to be given in pregnancy. Next is, how does warfarin act? So this is very important and this is very simple. So we'll follow the two graphs. On the top, we have dis carboxy factor 2, 7, 9, 10, which are non-functional. On the right side, we have factor 2, 7, 9, 10, which is functional. So these are carboxy. So for dis carboxy, non-functional, to get activated to normal carboxy 2, 7, 9, 10, we require vitamin K hydroquinone on the second point. So in this process, when the factors 2792 are getting activated, vitamin K hydroquinone gets automatically simultaneously changed into inactive vitamin K epoxide. Now this process keeps on happening. So vitamin K epoxide, which is now inactive, this vitamin K gets activated back by NADH to NAD. So there is an enzyme, epoxide reductase enzyme here, where it is shown as red. So epoxide reductase enzyme changes vitamin K epoxide to the active form of vitamin K hydroquinone. So once hydroquinone is generated, it will again convert inactive 27910 to active 27910. So this process goes on. So warfarin comes here. What does warfarin do? It blocks the conversion of blocks epoxide reductase. So now vitamin K epoxide will not get changed to vitamin K hydroquinone. Vitamin K hydroquinone will decrease. What will happen? Now the 27910 discarboxy form will not change into active 27910 and the synthesis of 27910 will automatically stop. So this is how warfarin works in the liver. If whatever 27910 are already circulating in the blood, warfarin does not touch them. It only stops the new synthesis in the liver. Therefore, there is a delayed action. It will take some time to act, but once it acts, it becomes permanent because it has stopped the factory of 27910. Whatever is circulating in the market, it is already there, but the factory has shut down now. Okay. Now, if warfarin comes, three things to remember. This epoxide graph, that it blocks epoxide reductase. It blocks the conversion of 27910 to active form in the liver. Warfarin, side effect bleeding. It is specially contraindicated in pregnancy. And always remember that warfarin has a lot of drug interaction. Lot of drug interaction. Heparin does not have drug interactions. Warfarin has a lot of drug interaction. So I'll just take on some important ones. So on the left side, there are drugs which increases warfarin action. On the right side, there are drugs which decrease warfarin action. So on the left side, we'll start on the left side. This appears complicated, but this is very simple to remember. So warfarin is metabolized by the cytochrome enzyme CYP2C9. So any drug which inhibits cytochrome enzymes, especially cytochrome 2C9, will increase the level of warfarin and the action of warfarin. So what are those drugs which inhibit or decrease the action of cytochrome isoenzymes, which will increase warfarin? So these are allopurinol, amiodarone, chloramphenicol, erythromycin, important one, metronidazole. So erythromycin, this group, chloramphenicol, allopurinol, these are important. So if you remember CY in the general pharmacology, cytochrome P452C9 inhibitors, they'll all increase warfarin action. Now, I told you in the beginning that warfarin is very tightly bound to plasma protein. So any drug which is also very tightly bound to plasma protein, it will displace it. So if, for example, if somebody loves the car and sits in the car, another person who is also very frantic for the car and also loves the car, he'll push the first person from the car and push him outside. Similarly, these warfarin is tightly bound to plasma protein. There are some drugs which also bind to plasma protein, so they'll push them out of uh, their binding from proteins, and they'll be loose form. And the warfarin loose form, free form is highly active. So the action of warfarin increases. Which are those drugs which have high plasma protein binding? Important ones: sulfonamides, sulfonamide group of antibiotics, indomethacin group in the NSAIDs, non-steroidal anti-inflammatory drugs, phenytoin and probenecid. So these drugs displace warfarin from protein binding sites. Warfarin becomes free, and it is available for action now. Free is more active, so the in action of warfarin is increased. Third is any drug which inhibits intestinal bacteria, for example, tetracyclines. So they will reduce the synthesis of vitamin K. Vitamin K, if it goes down in the body, we just talked about that warfarin is blocking vitamin K, activation of vitamin K in the liver, and vitamin K supply goes off. Obviously, warfarin action will be increased. So this is the third group. And the fourth is aspirin, because aspirin has antiplatelet action, and it also displaces warfarin from protein binding site. It is an NSAID, so it increases the levels and effects of warfarin. So there are four categories. One is cytochrome P450 inhibitors, warfarin level increases. Displaces from protein binding sites, warfarin level increases. Decreases vitamin K, warfarin becomes the king, because vitamin K was like competitive antagonist. So vitamin K decreases, warfarin action increases, and aspirin acting on both the above mechanisms. Now coming to the right side, which is decreased action of warfarin. So we talked about cytochrome enzyme inhibitors, which was allopurinol, erythromycin. Now cytochrome P450 enzyme inducers. So any drug which will induce these enzymes will increase the breakdown of warfarin. So warfarin level goes down, action decreases. Important cytochrome P450 enzyme inducers, always remember barbiturates, rifampicin, very important carbamazepine, anti-epileptic drug, and griseofulvin. Just remember these four drugs. These are more than sufficient for clearing most of the exams. Barbiturates, rifampicin, griseofulvin, carbamazepine. They are enzyme inducers. They'll induce the enzyme, increase the breakdown of warfarin, warfarin level goes down. Second, any drug which inhibits the absorption of warfarin. Warfarin is absorbed orally, we talked. So anything which decreases the oral absorption, for example, cholestyramine, will decrease the level of warfarin. And oral contraceptives. Now, these are important drugs because they increase the level of clotting factors. Oral contraceptives are prothrombotic type of drugs, so increase the chances of clotting in the blood. So they increase the levels of clotting factors, and therefore clotting factors increases, the warfarin action is decreased. These are important. So for warfarin, you can never forget that it is given orally. The action is delayed, and what it is not to be never to be given in pregnancy. It has a lot of drug interactions. Now I move ahead to the next slide, which is one question which comes over is why there is a delay of 1 to 3 days for the onset of effect with warfarin. Like you have started giving warfarin, but the anticoagulant action is not occurring. So what should you do? So the approximate half-life of already circulating clotting factors are 6 hours per factor for those 2, 7, 9, 10, 6 hours, 24 hours, 36 hours, 50 hours. So if you stop the factory in the liver, nothing comes out, output becomes zero. So whatever is circulating in the blood, it will die off within 6 hours, 24 hours, 36, and maximum 50 hours. So 50 hours is 2 days. So around 1 to 3 days, all these circulating clotting factors, they'll die, and they'll move off from the blood. So although the synthesis of clotting factors decreases within 2 to 4 hours, so the synthesis warfarin starts occurring in the liver within 2 to 4 hours, but the anticoagulant effect appears only after 1 to 3 days. This is because the clotting factors which are already circulating, they gradually decline over next 50 hours, and therefore there is a delay between initiation of warfarin and the anticoagulant effect. So what will happen for the first 5 days? What the physician needs to do? If you want an immediate anticoagulant action, what is to be done for the first 5 days? warfarin and heparin both are given together. Warfarin and heparin both are given together because warfarin will start acting in the liver, stop the factory, but this will take time, and heparin will act immediately on the circulating factors. So heparin will kill those factors and warfarin will stop. So by 1 to 3 days, once warfarin action starts manifesting, you can stop heparin. So first 4 to 5 days, give both heparin and warfarin together. After that, remove heparin and warfarin will continue. So this is a trend in operative like theaters, how they start anticoagulant therapy. Next is very important, like you always get a question, is difference between heparin and warfarin. So since we have gone through all of them, we will quickly cover this. Heparin and warfarin. Okay, just this is a trick now. Just look at this. Heparin has letter P. P for Punjab. So heparin has letter P. Now look what happens. We'll look at the chemistry. Heparin is sulfated mucopolysaccharide and warfarin is a coumarin derivative. So mucopolysaccharide, letter P. Heparin has P, polysaccharide also has P. Next is route. Heparin is given always parenterally, never intramuscularly, only intravenously or subcutaneously, but given parenterally. Warfarin is given oral. Parenteral also has letter P. So heparin P, polysaccharide P, parenteral P. Mechanism. Obviously, we have heparin activates indirect thrombin inhibitor. Heparin activates antithrombin 3, and this antithrombin 3 then kills factor 2A and 10A both. Warfarin inhibits, does not touch the circulating clotting factors. It goes into the liver, stops the factory, inhibits the synthesis of clotting factors 2, 7, 9, 10. Onset. Obviously, we have talked about heparin is immediate. It will go into the ground, kill everyone. Immediate action. Warfarin will stop the factory. Whoever are like wandering in the streets, they will keep on working till they die. So warfarin action is delayed. Heparin action is immediate. Then duration. Obviously, heparin is immediate action, short duration. It will come quickly, it will go quickly. So the duration of action is 4 to 6 hours. Warfarin will come after some time, but it will remain for a long time. So this is 4 to 6 hours duration that acts for 3 to 6 days. Then come to use. Obviously, if it has immediate action, it will be used to initiate therapy. And if this has delayed and a longer action, it will be used as maintenance therapy. Initiate therapy is to start, maintenance is like now at a lower level, you keep on taking for months. So the heparin is to initiate therapy, warfarin is for maintenance. Pregnancy, very important. Heparin is used during pregnancy and warfarin is contraindicated. Contraindicated means not to be given. Okay. Again, letter P. Heparin is P. Pregnancy is P. Okay. Then monitoring. We have talked about to check the levels, the amount of clotting that has occurred and the amount of the chances of bleeding. We monitor the action of heparin by measuring APTT. For warfarin, we measure it by PT or INR. Heparin is APTT, warfarin is PT or INR. Antagonist. So there is antidote, what we call as antidote. For heparin, it is protamine sulfate. For warfarin, because it is inhibiting vitamin, so vitamin K will become an antidote. Again, the letter P. Protamine has P, heparin has P. And the last interactions, we saw heparin does not have any drug-drug interactions, but warfarin has a lot of drug-drug interactions. So if you go and look at the top, heparin has P, used parenterally P, used in pregnancy P, protamine is the antidote P, chemistry is mucopolysaccharide P. So never forget this. We keep on struggling at the time of exam, which is given parenteral, which is used in pregnancy, warfarin or this. All P's are on one side. So if you just remember that all P's come onto one side, heparin is parenteral, heparin is used during pregnancy, protamine is the antidote of heparin. Heparin is short acting, immediate, short, initiate therapy. Okay. Now I move to the most important side, which is why are they used? What is the indication of using anticoagulant drugs? So one important question, like anticoagulant drugs, we always think that they dissolve a clot. Anticoagulants do not dissolve a clot once it is already formed. So if a clot is already there, it will not dissolve a clot. They are not for dissolving a clot. There is another group of drugs which are known as fibrinolytics. Fibrinolytics dissolve the clot. Anticoagulants do not dissolve a clot once it is already formed. So what does they do? Anticoagulants reduce the coagulability of the blood. So if a clot has not yet been formed, anticoagulants will prevent formation of the thrombus. So if it has not formed, it will prevent it for forming. But if a clot is already formed, they will not dissolve the clot, but they will prevent thrombus extension. So clots keeps on increasing in size. So it is a small clot, then it becomes bigger in size, bigger in size, bigger in size, and then it breaks off and goes in, gets the small particles get stuck in distant organs, which is known as embolism. So it will prevent the extension of thrombus. Whatever is formed, but it will not allow it to further grow into a larger length. So it will prevent extension of thrombus, it will prevent embolus, but it will not dissolve a clot. So which is also important. It prevents recurrences, but it does not dissolve a clot. So we keep on confusing that anticoagulant are clot dissolving. It is not clot dissolving, it is preventing the formation of clot, and if it is already formed, it prevents the extension of clot or embolic complications. Next, heparin. We have already talked about this. Heparin acts immediately. It has a short duration of action, so it will be used in acute treatment. Immediate the patient comes, you need to give heparin. If you want immediate anticoagulant action, warfarin is not to be given. Heparin is the drug of choice. The effect of warfarin comes after 3 to 7 days, but has a longer duration of action. So it is given for maintenance treatment. So as we talked in the previous slide, generally the two drugs are started together. Heparin gives cover for anticoagulant effect for the initial 4 to 7 days till the effect of warfarin is manifested. And once the effect of warfarin starts coming over, heparin is gradually stopped. So this is the approach to anticoagulant actions. Start both together. After 4 days, once heparin starts acting, the effect of heparin starts coming, withdraw. Warfarin starts coming, withdraw heparin. Then comes, why are they used? So indications important. Always remember the first and the most important. If you say this, it is more than enough. Deep vein thrombosis and pulmonary embolism. So deep veins are like deeper. There are veins which are carrying blood from the tissues to the heart. Those are veins, and there are some superficial veins. There are some deep veins. So in the deep veins, thrombosis occurs, and that thrombosis breaks off the part of some part of thrombus breaks off, it travels with the blood, gets stuck in brain, heart, at different organs, which is embolism. So pulmonary gets stuck in the lungs. So deep vein thrombosis and pulmonary embolism. The drug of choice is heparin or low molecular weight heparin, used in both the prophylaxis and treatment of DVT or PE. DVT is deep venous thrombosis, PE is pulmonary embolism. So heparin or low molecular weight heparin is used in the prophylaxis, and by prophylaxis we mean to prevent this. So for some high risk patients where there is a high chance that clot thrombus will occur, give upfront. It has not occurred till now, but start giving so that it does not occur. So that is prophylaxis or prevention. And once it has occurred, then that is called as treatment. So heparin or low molecular weight heparin is given for prophylaxis or treatment of DVT or PE. Heparin and low molecular weight heparin is given for prophylaxis of DVT and PE for all high risk patients. So which are those high risk patients? Which are bedridden. So we all know that if a person keeps on lying down, there is no movement, there is an increased chance of blood coagulating. Blood circulation decreases, and it starts धीरे धीरे like small starts coagulation, clotting at times. So any bedridden patient who is not moving, there is a very high chance of clotting to form, and then thrombus, and then embolism, which is a big complication. So as a prophylaxis, start giving low molecular weight heparin. So in high risk patients such as bedridden, post-operative, after operation, postpartum, after childbirth, post-stroke, after stroke happens, so there is paralysis. So the person cannot move. After leg fracture, also there is like person cannot move. So in these high risk patients, we have to give heparin and low molecular weight heparin to prevent the formation of thrombosis and pulmonary embolism, because these two are grave complications. Then low dose heparin prophylaxis for patients undergoing planned surgery. So anybody who has a planned surgery on after 5 days, 10 days, you start giving low dose heparin prophylaxis. So this significantly decreases the incidence of post-operative DVT. So if the person is getting small doses of heparin, low molecular weight heparin from 5 to 7 days, 10 days prior to surgery, after surgery there is a very significant decreased chances of uh, this DVT and PE. In this condition, low molecular weight heparin is the preferred drug because monitoring is not required. And when DVT-PE has already occurred, immediate heparin therapy followed by warfarin therapy is usually given, which is now continued for a few months. So I think my device has gone off. Can you see my screen?
Yes, sir.
Okay. So I'm more or less at the end of my presentation. I was talking here. So now the second indication is coronary angioplasty with or without stent placement. So what is this? So this is when which you normally call as heart attack. So what happens is there is a clot which blocks the artery of the heart. So there are coronary arteries which are supplying oxygen and blood to the tissues of the heart. So those gets blocked. So for that we do a coronary angioplasty. We put and then we put a stent so that stent bypasses that clot and starts supplying oxygen and blood. So coronary angioplasty with or without stent placement, heparin or low molecular weight heparin are generally used in this setting. And to prevent thrombosis, in this condition, fondaparinux is not used because it increases the risk of catheter thrombosis. So any stent or catheter which is there, the thrombosis will occur on the surface of the catheter. So fondaparinux is avoided, only heparin and LMWH is given. And third and important is cardiopulmonary bypass surgery or abdominal surgery, and heparin remains the drug of choice here. So if somebody asks about the use of anticoagulant drugs, the most important is DVT and PE, deep vein thrombosis and pulmonary embolism. Then we can come out with coronary angioplasty with or without stent placement, cardiac pulmonary bypass pulmonary surgery, and any forms of like major abdominal surgery or any other major surgery. So I think this is all.